As you can see, performing a chest X-ray or any X-ray on a child is not that easy. It is very important to have quality assurance when imaging children, as children are more sensitive to radiation and have a longer life expectancy, thus a larger window of opportunity for expressing radiation damage. One should always follow the ALARA principle, as low as reasonably achievable. The average radiation dose of a chest X-ray is 0.02 millisieverts, which is the equivalent of 3 days of background radiation. The Image Gently campaign suggests that one should only image when there's a clear medical benefit. One should also use the lowest amount of radiation for adequate imaging based on the size of the patient, and only imaging of the indicated area should be done. Imaging should be focused on the area of interest, and one should avoid multiple radiographs. Young children are radiographed in the anterior-posterior position. This enables the radiographer to watch the child's breathing and to expose on full inspiration. It is also easier to hold a patient straight and still, and one can watch the tube being centered and the beam collimated without having to turn around. When performing a chest X-ray on a child, it is important to hold the arms against the side of the head with the elbows flexed and positioned forward. Movement of the abdomen should One should observe the abdomen to ensure exposure on full inspiration. An exposure time of less than 0.02 seconds is ideal, and children's genitals should be protected by a lead rubber apron. If an adult is assisting or holding the child, they should wear a 0.5 millimeter lead equivalent. When assessing the quality of a radiograph, one must pay close attention to the collimation, the degree of inspiration, the penetration of the film, and whether or not the patient is rotated. To adequately collimate, it is very important that the patient is accurately positioned and lying still. As demonstrated in the video, this is often difficult without the use of a patient immobilization device or the assistance of a parent or guardian. Excessive collimation results in parts cut off, and poor collimation results in unnecessary radiation. The X-ray on the right demonstrates parts cut off, and the one on the left is an example of poor collimation and unnecessary exposure. If a radiograph is adequately inspired, the 6th anterior rib will intersect the middle part of the diaphragm. If a radiograph is underinspired, it results in enlargement of the heart, plethora of the lungs simulating a pneumonic process, mediastinal widening resulting in the suspicion of nodes. The hilar regions can also appear dense and may simulate adenopathy. The first example demonstrates an adequately inspired film with the 6th rib intersecting the right hemidiaphragm. This radiograph on the left demonstrates a poorly inspired film where the heart is enlarged, the mediastinum is widened and the hilar region is full, giving the impression of adenopathy. The radiograph on the left demonstrates the same X-ray, which is well inspired and actually appears normal. The next example further demonstrates how poor inspiration can simulate pathology and result in the overcalling or underdiagnosing of pathology. The penetration of a radiograph is affected by the exposure factors used. When a film is well penetrated, one is able to assess the vessels behind the heart, to visualize the pulmonary vessels in the lateral two-thirds of the lung fields, and provides adequate visualization of the trachea and proximal bronchi. Overpenetrated films result in black lung fields. And an underexposed radiograph results An underexposed radiograph looks very white and simulates airspace disease. Rotation is assessed by viewing the symmetry of the lengths of the anterior or posterior ribs. Rotation is the most common cause for the difference in radiolucency. It may result in missed or incorrect diagnosis. Rotation can also occur in the vertical axis, resulting in a kyphotic or lordotic film. This is assessed by the position. This is assessed by the If the medial ends of the clavicles are positioned at the level of T1 or T2, this is indicative of a lordotic film. This results in misregistration of location of pathology, and it also affects the cardiac outline. A rotated radiograph can simulate a heart abnormality. On the left is an example of tetralogy of Fallot, and on the right is a rotated film that is simulating a cardiac abnormality. It is not easy to acquire a good quality radiograph in a child. The best way to ensure good quality is good radiographic technique.